The Maryland Department of Health and Mental Hygiene, Hospital Breastfeeding Policy, Maternity Staff Training Program. Breast and Nipple Concerns, Session 11. Objectives. During this module, we will cover breast assessments. Prenatally, we will identify factors that may need to be watched more closely when a mother initiates lactation. We will identify breast issues that can occur postpartum, such as sore nipples, engorgement, blocked ducts, and mastitis, and discuss treatments of these situations, as well as ways to prevent them altogether. Generally, there is nothing a pregnant woman needs to do to her nipples to prepare for breastfeeding. Breasts vary in size, shape, color, and placement on the chest wall. Mothers should be reassured during prenatal breast assessment that breasts of all sizes and shapes are able to produce milk to sustain their infants. Prenatally, help empower women about their ability to breastfeed. Ask about and highlight prenatal changes that show their bodies preparing for lactation, such as enlargement of the breast and darkening of the areola. Breasts normally are more tender and increase in size during pregnancy. This is the final stage of breast growth. At this time, milk-producing glands are undergoing final development to produce milk, with increased vascular development and cell growth. During lactation, mothers' breasts often become enlarged. Always ask a mother for her permission to observe a breastfeeding session. During the feeding, assess the condition of the breast and ask the mother if she is experiencing any discomfort during feedings or when first latching. If you feel that you need to physically examine her breast to better assess an issue, always ask permission to expose or touch her breast. Ensure privacy while respecting cultural customs of modesty. Explain what you are doing and teach her about the changes in her breast that you are seeing during lactation. Breasts come in all shapes and sizes, but no matter the shape and the size, they should be evenly rounded, full, with a narrow space between the breasts. Breasts that are tubular in shape, with a wide space between them, or have a significant difference in size may be of concern for potential inadequate milk production. There are many different shapes and sizes of nipples. During prenatal breast exams, or once a baby is born, notice the mother's nipple type, looking to see if each is everted, flat, or inverted. Mothers with all three nipple types successfully breastfeed. Some with flattened or inverted nipples may need additional support and encouragement when initially learning to breastfeed, but there is no need to diagnose this during pregnancy. Often nipples can change shape during pregnancy, becoming more elastic or swollen or tight from fluid retention. There is no current evidence that supports nipple exercises. We do not want a mother to think something is wrong with her nipples and decrease confidence in her ability to breastfeed her infant. Skin elasticity of nipples can be a factor when having difficulties latching. Everted nipples protrude slightly when at rest and typically become erect and more easy to grasp when stimulated. Flat nipples, by contrast, do not protrude or become erect with stimulation. Inverted nipples retract back into the breast tissue. If nipple tissue is elastic, no matter what type of nipple a mother has, infants often can latch on with ease. Teach the mother to roll and stretch her nipples before feeding to help mothers with non-elastic skin latch their babies more effectively. Nipple shields are often marketed to mothers as a way to help with sore, flat, or inverted nipples. However, shields are not considered a good solution for latching difficulties and may cause decreased milk supply by creating a barrier and preventing direct skin-to-mouth contact and stimulation on the breast. In addition, these products are difficult for mothers to wean off of once breastfeeding is well established. Research only supports the use of nipple shields in premature infants with mothers who pump to maintain a milk supply, and in those cases, a lactation consultant should be consulted. Remember to check the nipple when slight pressure is applied to the edge of the areola, as nipples can look different when pressure is applied. If a mother has flat or inverted nipples, ask her first if she knows how to get the nipple to protrude. Often, if a mother's nipple will evert, she will know what hand position or pressure on her breast will help to avert it. The vast majority of women can and will make enough milk to sustain their infants. We've seen how breasts and nipples can look different without cause for concern. However, in other instances, some things you may observe should raise a red flag in the ability of the baby to latch on and breastfeed, or the mother to produce adequate amounts of breast milk. Some nipples that appear flat or inverted do not avert when a pinch test is tried. It is important in these cases to provide good support to the mother and build her confidence. It is helpful for the nurse to work with the mother when attempting to breastfeed, especially assisting her with getting the baby to latch. Sometimes things like having the mother roll her nipples between her fingers, pumping briefly, or using reverse pressure softening may help erect the nipple for the initial latch. Techniques on how to do this can be shown by the lactation consultant. Other devices marketed to evert the nipples require written hospital policy on their use and should be used only under the direct supervision of an international board-certified lactation consultant. Sometimes you may observe that a mother's nipples are very long or large compared to the size of the baby's mouth. This may make latching difficult or cause the baby to gag. Teach the mother to latch the baby onto the breast deeply. If the baby is unable to latch and nurse well, using a hospital-grade electric breast pump can help her build and maintain her milk supply. Keep in mind, as her baby grows, this will correct itself. Notice if the mother has signs of past breast surgeries, underdeveloped or tubular-shaped breasts. Consider initiating pumping to help build the milk supply for the women with these issues and refer to the lactation consultant for more technical assistance with the feeding plan. There is nothing special that needs to be done for the breast. There is no need to wash the breast before or after breastfeeding. In fact, the use of soap may cause drying and cracking of the nipples. Normal bathing practices will suffice. Prior to each feeding, some gentle massage may be helpful in stimulating the milk ejection reflex. After nursing, the mother can express a few drops of breast milk onto the nipple to help protect and heal the area. Women may benefit from the additional breast support provided by a proper fitting nursing bra. Many women will elect to use breast pads if they leak milk. Breast pads should not have plastic liners as this can increase the risk of infections. If using breast pads, they should be changed when dampened to prevent nipple discomfort. Breastfeeding should not hurt, however, some mothers may experience some slight tenderness at the beginning of a feeding in the first few days after delivery. Nipple soreness is a breastfeeding problem that often develops from nursing incorrectly. Soreness that does not go away in a few days or becomes so painful that the mother does not want to latch the baby on demands immediate attention and assessment to determine the cause. Improper positioning and latch on are the most common causes. Other reasons that can cause sore nipples include removing the infant from the breast without first breaking the suction, a breast pump that is improperly fit or has too high of a suction setting, thrush, bacterial infections, and tongue ties. Irritants to the breast and nipples, such as an allergy to creams or ointments, plastic-backed breast pads, and improper use of nipple shields should be avoided. Early sore nipples may feel like chapped lips, but can progress and become very tender and increasingly painful. The nipples may look red and raw and can even crack and bleed. Pain is discouraging and can inhibit the letdown reflex, causing engorgement and eventually reducing the milk supply. Reassure a mother that sore nipples will heal. The most frequent cause of sore nipples is poor positioning of the baby's mouth and the breast. Teach the mother to use different positions in holding the baby: football hold, side lying, or cross cradle. Sometimes just changing the positions can relieve the soreness. Check to be sure that the baby is positioned and latched correctly. Help her to achieve a deeper latch if needed. Suggest that the mother begin nursing on the least sore side first to improve comfort. If the baby does not remove himself from the breast, teach the mother to break the suction before removing him. Pulling a baby off the nipple, even just one time, can cause severe trauma to the nipple that can take several weeks to heal. If a yeast or bacterial infection is suspected, see that the mother receives treatment. Teach her how to care for the infection based on the provider's recommendations. If candidiasis, yeast or thrush, is suspected, both mother's nipples and baby's mouth must be treated, even if both don't present with symptoms. Mothers who receive antibiotics during their hospital stay or at any time during breastfeeding are at risk for developing thrush. Thrush will need to be treated but is very resistant and may take a while to resolve. Anything that comes in contact with the baby's mouth or breast milk, such as pacifiers, bottles, and pump parts, should be sterilized daily. Remove irritants, including nipple shields, allergens, plastic-lined breast pads, dampened breast pads, etc. Simply removing these allow the breast to heal and recover. Advise mother not to begin using them again until after symptoms resolve, and frequently change them to keep her nipples dry, preventing skin breakdown. Avoid putting drying agents such as soap, spray deodorant, shampoo, or any lotions containing alcohol on the nipples. Mothers using breast pumps should be assessed for proper use, including whether the flange fit is correct and if suction level is appropriate. Feeding devices used should be reevaluated to assure appropriateness. For example, nipple shields that are too small can cause irritation and soreness to the nipple. If an infant is suspected to have a tight frenulum, refer to a provider skilled in assessing and treating this. Tight frenulums, both on the upper lip and the tongue, can be the cause of improper latch and sore nipples. While in the hospital, encourage the mother to nurse early and often, at least 8 to 12 times in 24 hours. Observing an entire feeding will help to better assess for proper positioning and latch and allow for effective evaluation of a feeding. When assessing the latch, make sure the mother is getting a good amount of the breast in the baby's mouth, at least an inch back from the tip of the nipple. Look to see that the baby's cheeks and chin are touching the breast. Did the mother wait for the baby to open his mouth wide enough before allowing the baby to latch on? Make sure the mother waits until the baby's mouth is open wide, like a yawn, before latching. Have the mother support her breast with her hand using a C-hold or a U-hold for the entire feeding. This will help the baby to maintain a deeper latch and not slip off the nipple. When a mother's nipples are sore, have the mother apply a small amount of expressed breast milk or colostrum onto the nipple after each feeding. This will help to moisturize and soothe sore nipples. If the mother is using a nipple cream for soreness, make sure it is safe for the baby to ingest. Check the ingredient list and specific manufacturer instructions for safe use. Products that have been USP certified are independently tested for product purity. If your institution uses gel pads to treat sore nipples, rinsing the breast and nipple area before feeding is recommended. A baby's suck is often strongest at the beginning of a feeding to elicit a milk letdown. Applying a warm compress a few minutes before a feeding can facilitate letdown, or having the mother start the feeding on the least sore side first often will help alleviate soreness. Nipple discomfort is typically greatest on baby's 3rd to 5th day of life and decreases or stops by the 7th to 10th day. By 2 weeks, there should no longer be any nipple discomfort. If pain is still present after 2 weeks or continues for the entire feeding, the infant's latch needs to be reevaluated. Do not tell a mother to stop nursing to give her nipples a rest. This could cause engorgement and increased breast pain and may lead to decreased milk supply. Avoid limiting the length of feedings or use of nipple shields. These will not help the soreness and may increase the risk of breastfeeding complications. In the first few days, it is normal to experience increased fullness due to increased milk volume and vascularity of the breast. Engorgement results from breast milk not being adequately removed, causing milk stasis. Breast becomes hard, shiny, painful, and hot to the touch. When the breast becomes overly full, venous and lymphatic drainage are obstructed, decreasing milk flow and increasing interstitial edema. If engorgement continues, feedback inhibitor of lactation will occur, causing a decrease in milk supply. Between days 2 and 5, most mothers experience changes in their breasts as milk flow and circulation increases. Vascularity of the breast increases to provide the additional nutrients needed for milk production. The mother's breasts become noticeably fuller. If a mother misses or skips a feeding or does not feed at least 8 times in 24 hours, this will increase her chances of becoming engorged. The combination of milk not being removed and swelling from congestion can cause the nipples and the areola to be flattened, making it harder for the baby to latch, resulting in less milk being removed. When a mother uses supplements or pacifiers, milk is not being removed, which causes milk stasis and sets the mother up for engorgement. Following the 10 steps has been shown to reduce the incidence of engorgement and breastfeeding difficulties. The best practices outlined in each of the 10 steps helps to prevent breastfeeding difficulties that can lead to engorgement. Milk removal is essential for milk production. Frequent breastfeeding during both day and night is one of the most effective ways to relieve and prevent engorgement. Observe a feeding and improve the latch and positioning when needed. If a baby is not latched on well or deeply, the baby most likely will not be able to remove milk effectively, leading to engorgement. Sometimes just correcting the latch is all that is needed. If the breast has become too full, the nipple may flatten, making it more difficult for the baby to latch effectively. Teach the mother to massage her breast prior to feeding or express a small amount of breast milk. This will soften the breast and help the baby to latch on. Encourage the mother to allow the baby to finish one side completely before offering the second breast. This will help with emptying of a full breast. Briefly apply warm compresses before feeding to stimulate letdown. Overuse of heat can add to congestion. Cold is always a good choice. It will help to decrease the swelling in the breast so the milk can flow easier. If needed, a mother can take ibuprofen to help reduce pain and swelling while she continues to nurse the baby. Engorgement is a serious problem if not managed effectively and immediately. Further, more serious complications can occur. While engorgement can lead to a diminished milk supply, it can also lead to plugged ducts or mastitis and result in decreased weight gain for the infant and eventually premature weaning. Encourage all mothers to rest or sleep when the baby does. Family and friends can help with child care and household chores. Advise the mother to call her doctor immediately if her breasts are red and tender and she is experiencing flu-like symptoms or if she has a fever. A plugged, blocked, or clogged duct is a small area of the breast that has developed localized milk stasis. The breast is usually painful in a localized area with reddening over the area of the plugged duct. A mother can often identify exactly where the plugged duct is on her breast. Milk has formed but is not drained from the breast. Typically, a woman will complain of pain or tenderness where a lump has formed, but will not have a fever or other signs of infection. Keep in mind that besides feeling pain, mothers with a plugged duct may have fear due to finding a breast lump. Reassure the mother that plugged ducts are not unusual, especially in the early days, can help them to feel confident as they continue to breastfeed. Plugged ducts are most frequently caused by obstruction of milk flow and inadequate removal of milk. Because milk stasis can lead to both engorgement and plugged ducts, the same mismanagement can lead to either complication. Besides infrequent and missed feedings, babies with weak sucks may not adequately remove milk, leading to milk stasis and potentially clogged ducts. Once again, this can occur when babies are not allowed to finish on one breast before moving to the next or ending the feeding session. Because a plugged duct can lead to more serious complications like mastitis, it is important for the mother to deal with plugged ducts early. As with other similar concerns that lead to milk stasis, nursing at least 8 times, if not 10 to 12 times in 24 hours is necessary. Encourage the mother to nurse her baby with his or her chin pointed in the direction of the plugged duct and change position frequently. Have her nurse the baby on the affected breast first, allowing the baby to use a more vigorous suck to drain the milk from the breast. Massage the area gently before and during feedings and work towards the nipple. Using a warm compress while doing so or massage while in a warm shower can help facilitate a plug removal. Some mothers find using a vibrating handle of an electric toothbrush to massage the area during a feeding also can help break up the clog. For situations where mothers are unable to put baby to breast, empty the breast using hand expression or a breast pump. Once the obstruction has been removed, it may either be reabsorbed or expelled with the milk. It can be seen as a thick, stringy clump on the nipple and removed. There is no danger to the baby if swallowed. Encourage the mother to rest, eat well, drink fluids, and accept all offers of help. Again, if she is experiencing flu-like symptoms or fever, this should be reported immediately to the mother's doctor. Mastitis can occur suddenly and unexpectedly. It often occurs shortly after sore or cracked nipples have healed. The nipple trauma and fatigue following childbirth have left the mother susceptible to infections. If left untreated, milk stasis can progress to mastitis, a breast infection. Mastitis will present as a red, tender area on the breast and may progress to flu-like symptoms, including chills, fever, and malaise. Mastitis can also occur when a mother has experienced some trauma to the nipple, along with not removing milk adequately. With the skin of the nipple no longer intact, it can become a portal of entry for bacteria. Emphasize to the mother that if she is having mastitis, this is an infection in the breast, not in the milk. The milk is perfectly safe to feed to the baby, and feeding may relieve some discomfort. Make sure the mother empties her breast. She should nurse frequently. Suggest trying gentle massage during the feeding. Reassure her that nursing will not hurt the baby. If she cannot nurse, use the breast pump every 2 to 3 hours and encourage plenty of rest and fluids. If symptoms do not resolve within 12 to 24 hours, the mother needs to be referred to her physician for treatment. This is a medical condition that needs to be treated with antibiotics. Occasionally, some physicians will recommend that mothers stop nursing for a period of time. It is not necessary and not recommended, as continued nursing and milk removal is part of the recommended treatment. It is important to pay attention to a mother's breasts and observe a feeding to assess her technique for correct positioning and latch. Provide advice at this time to correct areas of concern will support a mother to breastfeed while helping her to prevent common complications.